Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here on the beautiful central coast of California. Thanks very much for joining me today. I'm delighted to have you with us, and I am delighted to have the very esteemed Dr. Hugh Wilson as my first guest. Dr. Wilson, pathologist, thanks very much, surgical pathologist.
That's correct.
Thank you very much for being with us today.
Thank you for having me.
Dr. Wilson, before we get on to our very important topic, colon cancer, that I want to talk about today, let's give a little background about how someone becomes a surgical pathologist and what your week is like. For example, you went to medical school and you did residency, so tell us a little bit about that.
So, like all doctors, people in the military say you're a soldier first and you're a radioman second, or whatever your MOS is, right? In medicine, we're a physician first and then you're a specialist second. So, college, medical school, internship, and then residency is where I specialized in pathology. And the typical pathologist in practice, medical practice today, does both surgical pathology and clinical pathology, which is the laboratory. But both of them, what they have in common is that it's not a specialty that's built around an organ system. It's a specialty that's built around a series of techniques, diagnostic laboratory techniques to diagnose medical conditions.
Okay, so Dr. Wilson, I recall from, I think it's Latin, pathos means, well, it's pathology means disease. Essentially, there's something wrong.
That's correct.
Pathologic, that's where we get the term pathological. There's something wrong or deranged. And so I think technically the pathologist, the ogist part of pathologist means the studier of disease, correct?
That's correct. Pathology is the study of disease, as opposed to, so for example, anatomy is normal anatomy. What is the normal human anatomy? Whereas pathological anatomy would be abnormal, diseased anatomy.
Got it. So Dr. Wilson, before we get into talking more about the specifics of colon cancer, what's your week like, a surgical pathologist? What do you wake up in the morning and do?
Well, the first thing I do is panic. No, just kidding. So typically, my day begins with receiving specimens. So surgeons and gastroenterologists and other physicians who have seen patients and have decided that that patient needs a biopsy or an excision, they then send it to the laboratory. They send it to the laboratory in a preservative, and then that tissue can be processed into a small slide, which is a very thin piece of tissue that we can actually pass light through. We use transmitted light. So the light that comes through the tissue is then focused by the microscope lens onto the eyepieces, so we can see a magnified view of the tissue. So the process is we receive the tissue, we make sure it's adequately preserved, we process it so that it's firm enough to be sliced thin. Then after it's sliced, we stain it to highlight details, and then we can look at it under the microscope. And the day goes on with routine specimens that come in that way, and then specimens that need to be evaluated right away in the operating room, so that the surgeon knows how to proceed with his operation.
Okay, so you do a lot of examination of tissue under the microscope.
Yes.
And you're giving feedback to the doctor and the team, and then, of course, the patient about what you see under the microscope.
That's correct.
And Dr. Wilson, this is actually a perfect segue into talking about colon cancer and polyps and benign tumors as opposed to malignant tumors. So in our previous episodes, you've taught me a lot, and we've taught the audience, I hope. For example, if we look at the skin, everybody knows what a mole is. The medical term is nevus. Now, not every mole or nevus is a malignant melanoma.
Correct.
And all over the body, many people have heard about lipomas. That's a benign fatty tumor. It's still a tumor, but it's a benign tumor of fat cells.
Right.
Now, there's also something called a liposarcoma, which is a fatty tumor, but that's malignant.
That's correct.
Now, we know that in the colon, we can have a benign polyp. I think they're actually quite common. But some of those polyps are not benign, they're malignant, which means they're cancerous. So how do you, as a surgical pathologist, when you're given a specimen, let's say the gastroenterologist does a colonoscopy and then a polypectomy, which the gastroenterologist will remove the polyp. Now, how do you tell whether or not that's a benign polyp or a cancerous growth, a cancerous polyp? What do you look for? How do you know? Just by looking under the microscope.
So the features that would distinguish, that a tumor is simply an abnormal growth, and as you said, it can be benign or malignant. Benign tumor, it might press up against the surrounding tissues, but it does not invade the surrounding tissues, and it doesn't spread anywhere. A malignant tumor will do those two things. It will invade surrounding tissues, and it can spread to other points in the body. That invasiveness is something we look for under the microscope. So, the tissues are made up of cells. So when we're magnifying the tissue under the microscope, we're looking at individual cellular features and then also how those cells arrange themselves into a tissue. And so malignant tissues will show invasive behavior. They'll invade into the surrounding tissues. Now, one of our hopes, though, let's stick with the colon cancer and the endoscopy, the colonoscopy that the gastroenterologist does. He's using a flexible fiber optic microscope, basically, to look at internal tissues and identify a polyp, which is a growth up above the surface of the colon. And when he takes that out, the hope is what he's going to find is that a tumor that's not yet invasive. Because if it's not yet invasive, it's completely curable. So, but for me, if it's not invasive, how do I tell it's malignant? It's the way those cells arrange themselves to one another and the things they stop doing. In the colon, for example, colon epithelial cells, the lining cells of the colon, typically make mucus, which is a slippery substance that helps the food particles pass through. A malignant tumor or a pre-malignant tumor will stop making mucus. And then the cells will have an abnormal arrangement. So instead of being layered across the bottom layer of the epithelium, they will start to grow upward. And in a benign condition, they respect each other's space. In malignant, they don't. They start piling up on top of each other and invading each other's space, as it were. So there are ways that the individual cells react to each other. And then within the cell, that a cell has, it's the smallest unit of life, right? It can reproduce itself, consume energy, and produce waste. And it's contained by a membrane, and then it has a semi-liquid central portion called the cytoplasm, and another unit called the nucleus, which is sort of that's where all the information on how the cell should operate is contained. A benign cell has a relatively low ratio of nucleus to cytoplasm, whereas a malignant cell has a higher ratio of nucleus to cytoplasm. So there are tissue features and there are cellular features.
Okay, so Dr. Wilson, once again, so the gastroenterologist does a polypectomy, for example, biopsy, and you get the specimen, and then you do your preparation and you can look under the microscope. But what about in cases where it looks like there's some what we call cellular atypia? Like there's some of the nuclei look unusual, some of them don't. Aren't there special stains and special markers that you can perform, like little almost biochemical tests that you can perform to distinguish between a malignant cell and just a benign, highly proliferating cell, like in a benign polyp? Are there markers or special stains you can do?
Yes, well, one of let's say for invasion, for example, if we're suspecting some very early invasion, the bottom layer of the epithelium, the lining of the colon, has what's called a basement membrane. We can stain that and see if it's we have a stain that will highlight that, tell us if it's still intact. We can also, for example, if there's I said that the malignant cells stop making mucin, we have stains that can highlight mucin to see how much is there versus is it a normal amount, is it a decreased amount, or is it absolutely gone? Once we think that there is perhaps a malignancy there, we have other markers we can use to see what kind it is.
Okay, so Dr. Wilson, you've taught us in other areas of the body, for example, with lung cancer. We've spoken about how chronic inflammation, whether it may be chronic smoking, that irritant from the smoke, maybe air pollution can irritate the bronchial lining, and that can bring about a malignant change. And those cells can go elsewhere. In other words, they can break off and go elsewhere, and you've called that metastasizing. Isn't that correct?
That's correct.
So for example, in the colon, or almost anywhere in the GI tract, the stomach, esophagus, small intestine, large intestine, the colon, when the cells are malignant and some break off, they can go to other parts in the body and take root. Isn't
Yes.
that correct?
Yes.
So that's a much more advanced cancer. The stage, if we were to stage the cancer,
Yes.
that would be much more advanced.
Yes.
So how do you help the gastroenterologist and the oncologist with the so-called staging of a tumor? How do you help with that?
So the the earliest stage would be completely confined to the lining layer of the colon, right? And we can see that even on an endoscopic biopsy, the biopsies that are done at colonoscopy or esophagogastroduodenoscopy from above. We can see if it's confined to the superficial layer. Now, if it has invaded below that, that's sort of difficult to see until there's been a surgical excision. But at the time of the surgical excision, we can see how deep through the layers of the colon has the tumor invaded. We can also then, the surgeons will take out, in addition to the colon, some of the surrounding tissues that attach the colon to the peritoneum. And within those tissues, there are lymph nodes. And that's typically the first place that a cancer would metastasize to. So we can find the lymph nodes, examine them, see if any of them have cancer, and if so, what proportion of them have cancer.
Okay, so you've taught us that one of the characteristics of a malignant tumor as compared to a benign tumor. So a benign tumor might grow incredibly large.
Yes.
I've seen lipomas as a plastic surgeon that are huge, but they push the tissue adjacent kind of aside and continue to grow. A malignant tumor will actually invade, isn't that correct?
That's correct.
Like those cells grow into the adjacent tissue, as well as one or two cells breaking off and taking root somewhere.
That's
Isn't that correct?
Yes. So like a benign tumor that might push up, it'd be like if your neighbor widened his driveway, so he's on your property, but he's not really hurting you. It's another matter if he starts throwing rocks at your house and breaking your window and coming on inside. That's what a malignant tumor would do. A benign tumor might just take up some space in your yard, but a malignant tumor breaks the window and climbs in. It's invasive. And then, as you said, distantly, it can get into either the lymph system or the blood system and travel to distant sites. Now so we can help the gastroenterologist or the oncologist with that as well, but it typically takes a biopsy at that other site. From the surgical excision of the tumor, I can see the depth of invasion in the wall of the colon and any metastases to associated lymph nodes. Distant metastases, say for example to the liver, I would also need a liver biopsy to determine if there's cancer there.
Okay, so Dr. Wilson, that's another key point. Now we know, for example, plastic surgeons, we take care of a lot of breast cancer. So we know that when the breast cancer goes somewhere else, it may continue to grow locally within the breast. It could go to the lymph nodes. The first lymph node it goes to, we typically call the sentinel node.
Right.
But when we can predict if it's going to break away, it goes to certain predictable spots.
Typically.
Right? As I recall, breast goes to liver and bone and brain, I think. So,
yes.
Where does colon cancer go? Can we predict where it's going to metastasize to?
Yes.
If it's going to?
The most common site for it to go to is the liver.
The liver.
By far, but it can also go to other spots as well. It can go to the lungs. But by far the most common site, other than lymph nodes, would be to go to the liver.
Okay. So Dr. Wilson, one very important role I think we can play in educating the public. We've talked about some scary terms, malignancy, metastases, colon cancer, but I want to emphasize that much of the work that you do will be diagnosing a polyp that is cancerous, but it hasn't gone anywhere. It's totally and completely curable, but you can help the gastroenterologist and oncologist stage it and grade it and teach the patient about what they have or had, and the patient is totally and completely cured. Isn't that correct?
Yes, that's correct.
So because, I think what we need to do is emphasize, because the person has a polypectomy and a biopsy and a pathologic exam, that doesn't mean that it's threatening to their life.
No, and that's there are multiple purposes for colonoscopy. Screening colonoscopy as opposed to diagnostic. Screening colonoscopy is a completely healthy person who comes in to be checked, just in case, right? And so there's a couple of goals. One is early diagnosis, right? We know with all cancers, the earlier you find it, the better the prognosis, the more likely the patient is to have a good outcome. If it's found early, it's much more treatable. And then the second goal is, if you find one of those pre-malignant or actually malignant polyps, but it's still confined to the lining layer, well, that's curative. It's actually preventative. So colonoscopy is both early diagnosis and prevention. By taking that polyp out, it will never become cancer. It'll never invade and it'll never spread somewhere else. It's one of the best things that adults can do for themselves, is to go for their screening colonoscopies.
Well, Dr. Wilson, that's great information to emphasize. I appreciate that very much. Now, you also mentioned EGD, I think.
Yes.
The gastroenterologist not only does colonoscopy, and you assist with analyzing and doing biopsies of polypectomies, removing polyps, but he may oftentimes, the gastroenterologist, he or she may biopsy an esophagus that looks unusual, may biopsy a stomach lining that looks unusual. Isn't that correct?
Yes, that's correct.
So you can help with distinguishing between esophagitis or Barrett's esophagus, or a malignant tumor of the esophagus, or lining of the stomach. Isn't that correct?
Yes, that's correct. And also the first part of the small intestine, called the duodenum. The gastroenterologist will also look there and sample there. People have heard of celiac disease or gluten sensitivity. They can sample the first part of the small intestine, called the duodenum. In the stomach, if someone has gastritis, the biopsy can be used to determine if they have an infection, a bacterial infection with Helicobacter, which can be treated with antibiotics and can make the gastritis go away. And then again, also for ulcers and for tumors. In the esophagus, they can biopsy for tumors or a pre-malignant condition called Barrett's esophagus, or Barrett's metaplasia. Metaplasia being a normal tissue in an abnormal location, but which can predispose to cancer.
Well, Dr. Wilson, I really appreciate you coming on and teaching us a lot. We only have a few seconds. I have one more question for you.
Sure.
Oftentimes a patient, after undergoing a procedure with the plastic surgeon, will sit in the office afterward and talk about the results and counsel them about the future, and they'll oftentimes come into the gastroenterologist and sit and talk about what the biopsy showed. I wonder if a patient is interested in sitting with the pathologist and, say, looking at the slides. Is that possible, that you could actually sit with a patient and teach them what their biopsy shows?
Absolutely. We do it upon occasion. It's not that common because typically there's at least one doctor between us and the patient. So, for example, the patient sees his primary care provider, who sends him to a gastroenterologist who does the biopsy, and the patient seldom takes the effort to schedule an appointment with the pathologist. But it does happen, and we're always happy for it.
I think it'd be very interesting, I think, to sit with people and teach them about what you see under the microscope.
Yes.
Dr. Hugh Wilson, surgical pathologist, we're lucky to have you here in Monterey County on the beautiful coast of California. Thank you very much for being here, and I hope I can convince you to come back and be a guest again.
I love it, Dr. Morwood. I'll be back anytime you like.
Dr. Hugh Wilson, surgical pathologist. Once again, I'm Dr. David Morwood. This program is the Doctor Is In television program. I'm a board-certified plastic surgeon right here in beautiful Monterey, California. We're going to take a very brief pause for a very good cause. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline.